Hello everyone, welcome to Clinical Horizon. I am Dr. Mohan Gayen. In clinical medicine, knowledge is essential, but it is your skills and the instruments in your hands that transform that knowledge into action. Every day in wards, emergency rooms, and intensive care units, we rely on a set of essential medical instruments to support breathing, maintain circulation, administer treatment, monitor patients, and perform life saving procedures. In this session, we will go beyond simple identification. We will understand each instrument in terms of its structure, how it works, when it is used, the precautions we must take, and the clinical insights that every doctor should know. By the end of this masterclass, you should be able to recognize these instruments confidently and understand how to use them safely in real clinical practice. Let's begin. Our first instrument is Ambu bag or bag valve mask. The Ambu bag or bag valve mask is one of the most important life-saving devices in medicine. It is a manual resuscitation device used when a patient is unable to breathe adequately. The bag valve mask, whose full form is Artificial Manual Breathing Unit, is one of the most important life-saving devices used in emergency and critical care. It is a manual resuscitation device that provides positive pressure ventilation to patients who are not breathing adequately or are completely apneic. The device consists of a self-inflating compression bag, a one-way non-rebreathing valve, an oxygen inlet with a reservoir, and a face mask that forms an airtight seal over the patient's nose and mouth. When the bag is compressed, oxygen is delivered into the lungs. When released, the bag refills automatically with fresh oxygen, preparing for the next breath. With an oxygen reservoir attached, it can deliver a very high concentration of oxygen, close to 100%. The bag valve mask is used in cardiac arrest, respiratory failure, apnea, drug-induced respiratory depression, and for pre-oxygenation before securing a definitive airway. It is also used during the transport of critically ill patients. Proper technique is essential. The airway must be opened using the head tilt and chin lift maneuver or a jaw thrust maneuver if cervical spine injury is suspected. Ventilation should be given at a controlled rate, usually 10 to 12 breaths per minute in adults, with each breath producing visible chest rise, which indicates effective ventilation. Excessive pressure can lead to gastric distension, aspiration, or barotrauma, while poor mask seal can lead to ineffective ventilation. Therefore, the key to safe use of the bag valve mask is gentle, controlled ventilation with proper airway positioning and a good mask seal. In emergency care, this device is often the first and fastest method to restore oxygenation, making it a truly life-saving extension of the clinician's hands. This is the endotracheal tube or ET tube. The endotracheal tube is the gold standard for securing a definitive airway. It is a flexible tube inserted through the mouth or nose into the trachea, creating a protected and controlled airway for ventilation and oxygen delivery. The distal end of the tube has a beveled tip that facilitates smooth passage through the vocal cords. Just above the tip is the Murphy's eye, a side opening that allows continued airflow if the main lumen becomes partially blocked. The tube contains an inflatable cuff near its distal end. When inflated, this cuff seals the trachea, helping to prevent aspiration and ensuring effective positive pressure ventilation. The pilot balloon allows the clinician to monitor cuff inflation and pressure, and the graduated markings along the tube help guide correct insertion depth. Endotracheal intubation is indicated in patients with impaired airway protection, such as coma with a low Glasgow coma scale, as well as in severe respiratory failure, major trauma during general anesthesia, and in cardiac arrest. After insertion, confirming correct placement is critical. The clinician must look for bilateral chest rise, listen for equal breath sounds on both sides, and confirm with end tidal carbon dioxide monitoring, which is the most reliable bedside method. A chest X-ray is then used to confirm final tube position, with the tip ideally located between the second and fourth thoracic vertebral levels. Complications can occur if placement is incorrect or if the tube is not managed properly. These include esophageal intubation, right main bronchus intubation, tracheal mucosal injury due to excessive cup pressure, and ventilator associated infections. Therefore, successful use of the endotracheal tube depends on proper technique, correct placement, and continuous monitoring. This is Ryle's tube or nasogastric tube. The Ryle's tube, also known as a nasogastric tube, is a flexible tube inserted through the nose into the stomach to allow access to gastric contents. It is commonly used for enteral feeding, gastric decompression, administration of medications, and for diagnostic aspiration of gastric contents. The tube is designed with multiple side holes at its distal end to facilitate drainage and feeding. It also contains a radio-opaque line to allow visualization on X-ray and graduated markings along its length to guide correct insertion depth. Before insertion, the appropriate length of the tube is measured using the nose to ear to jiffy sternum method or NEX method. The tube is then lubricated and gently passed through the nostril, advancing it while the patient swallows to facilitate passage into the esophagus and stomach. After insertion, confirmation of correct placement is essential before the tube is used. Initial confirmation can be done by aspirating gastric contents and checking the pH, but the most reliable method is radiographic confirmation. There are important contraindications to remember, including base of skull fracture and severe facial trauma, where nasal insertion can be dangerous. Potential complications include misplacement into the airway leading to aspiration pneumonia, nasal irritation, sinusitis, and in rare cases, esophageal injury. During feeding through a Ryle's tube, the patient should always be kept in a head-up position, ideally at an angle of about 30 to 45 degrees to reduce the risk of aspiration. When used correctly, the Ryle's tube is a simple yet highly effective tool for nutritional support, gastric decompression, and clinical management of many medical conditions. The Foley catheter is an indwelling urinary catheter used for the continuous drainage of urine from the bladder. It has two separate channels, one for urine drainage and another for inflation of a retention balloon located near the tip. Once the catheter is inserted into the bladder, the balloon is inflated with sterile water to keep the catheter securely in place. This catheter is commonly used in acute urinary retention, for strict monitoring of urine output in critically ill patients, during perioperative care, and in certain neurological conditions affecting bladder function. The balloon must never be inflated until free flow of urine is clearly seen. Inflating the balloon while still in the urethra can lead to severe urethral trauma and bleeding. There are also important contraindications. Insertion should be avoided in patients with suspected urethral injury, especially in the setting of pelvic trauma, where signs such as blood at the urethral meatus may be present. Complications associated with Foley catheter use include urinary tract infection, urethral injury, catheter blockage, and bladder spasms. To minimize these risks, strict aseptic technique during insertion, proper catheter care, and early removal as soon as clinically indicated are essential. This is urinary drainage bag or urobag. The urinary drainage bag is an essential component of a closed sterile urinary drainage system connected to the Foley catheter. It is designed to collect urine continuously while maintaining a sealed system, which helps reduce the risk of infection. A key feature of the drainage bag is the anti-reflux valve, which prevents urine from flowing backward toward the bladder. This is important because backflow can introduce bacteria and lead to infection. For safe and effective functioning, the drainage bag must always be kept below the level of the bladder. This allows urine to drain by gravity and prevents reflux into the urinary tract. The bag should be emptied regularly using the outlet port, taking care to maintain sterility and avoid contamination. This simple but essential practice of proper positioning and handling plays a major role in preventing catheter associated urinary tract infections, one of the most common hospital acquired complications. When used and maintained correctly, the urinary drainage bag helps ensure safe, continuous, and hygienic urine collection in patients requiring catheterization. This is peripheral IV cannula. The peripheral intravenous cannula provides direct and reliable access to the venous system, allowing rapid administration of fluids, medications, and blood products. It consists of a flexible plastic cannula mounted over a sharp introducer needle, along with a flashback chamber that confirms entry into the vein by showing blood return. Cannulas are color coded according to their gauge, which helps in quick identification in clinical settings. The commonly used color coding is as follows: orange, this is 14 gauge for major trauma and massive fluid resuscitation; grey, 16 gauge for rapid infusion and blood transfusion; green, 18 gauge for blood products and emergency drugs; pink, 20 gauge for routine intravenous fluids and medications; blue, 22 gauge for elderly patients or those with fragile veins; yellow, 24 gauge for children and very small veins. There is also a cannula of 26 gauge. Color coding is violet. The key principle to remember is that the lower the gauge number, the larger the bore and the faster the flow rate. Possible complications include extravasation of fluids into surrounding tissues, thrombophlebitis, hematoma formation, and local infection. To minimize these risks, insertion must be done using strict aseptic technique followed by secure fixation of the cannula and regular monitoring of the insertion site. When used correctly, the peripheral intravenous cannula becomes a critical gateway for life-saving treatment in both emergency and routine medical care. These are some emergency life-saving drugs. In emergency and critical care settings, certain medications are used to rapidly stabilize vital functions and prevent organ damage. Adrenaline is a key drug in cardiac arrest and anaphylaxis. It stimulates both alpha and beta receptors, increasing heart rate, cardiac contractility, and peripheral vasoconstriction, thereby improving perfusion during resuscitation. Atropine is used in symptomatic bradycardia. It works by blocking vagal influences on the heart, leading to an increase in heart rate and atrioventricular conduction. Hydrocortisone is used in severe asthma, anaphylaxis, and adrenal crisis. It helps reduce inflammation, stabilize cell membranes, and support the body's stress response. In states of shock, particularly septic shock, noradrenaline is the first line vasopressor. It primarily acts on alpha receptors to produce vasoconstriction, thereby raising systemic vascular resistance and blood pressure. Dopamine has dose-dependent effects. At moderate dose, it improves cardiac output, while at higher doses, it causes vasoconstriction and increases blood pressure. All of these medications are powerful and time critical and must be administered with continuous monitoring of vital signs, cardiac rhythm, and perfusion parameters. Syringes and needles are fundamental instruments used daily in clinical practice for administering medications, drawing bloods, and delivering vaccines. A syringe consists of a graduated barrel that allows accurate measurement of fluid and a plunger that creates pressure for injection or negative pressure for aspiration. A needle is made up of a hub, hollow shaft, and a beveled tip, which is designed to pass through tissue smoothly with minimal trauma. Needles are available in different gauge size, selected according to the purpose. Larger bore needles are used for drawing blood or handling thicker fluids, while finer needles are used for intramuscular, intravenous, or subcutaneous injections. Safe practice is essential. All injections must be performed using strict aseptic technique. Used needles must never be recapped. They should be disposed of immediately in a puncture-proof sharps container to prevent needle stick injuries and transmission of infection. This is lumbar puncture needle. The lumbar puncture needle is used to obtain cerebrospinal fluid from the subarachnoid space for diagnostic and therapeutic purposes. It is a long hollow needle with a removable stylet which prevents skin or soft tissue from blocking the lumen during insertion. The puncture is performed in the lumbar region below the level of the spinal cord, making it a safe site for access. In adults, the preferred insertion site is the L3-L4 or L4-L5 intervertebral space, identified by drawing an imaginary line between the highest points of the iliac crests, known as the Taffier's line. In children and infants, the spinal cord ends at a slightly lower level, so the needle is inserted slightly lower, usually at the L4-L5 or L5-S1 interspace to ensure safety. Lumbar puncture is commonly used to diagnose meningitis, subarachnoid hemorrhage, and demyelinating diseases, and it also allows measurement of cerebrospinal fluid opening pressure. Important contraindications include raised intracranial pressure due to a mass lesion, local infection at the puncture site, and bleeding disorders or anticoagulation, which increase the risk of complications. Possible complications include post-lumbar puncture headache, bleeding, and infection, though these are minimized with proper technique and strict aseptic precautions. Now the IV set and blood transfusion set. The intravenous infusion set is used for administering fluids and medications directly into the bloodstream. It consists of a spike to pierce the fluid container, a drip chamber to visualize flow, tubing to carry the fluid, and a flow regulator to control the rate of infusion. Many sets also include an injection port for adding medications. A blood transfusion set has a similar overall design but with one important difference. It contains a special inline filter, usually with a pore size of about 170 to 200 microns. This filter is designed to remove clots, fibrin strands, and cellular debris from blood products before they enter the patient's circulation. Using the correct transfusion set helps prevent complications such as microemboli, transfusion reactions, and line blockage. Proper identification of the correct set, correct priming, and careful monitoring during transfusion are essential to ensure safe and effective intravenous therapy. These are different types of intravenous fluids. Intravenous fluids are essential therapeutic agents used to maintain circulation, restore volume, and correct electrolyte imbalances. Normal saline or 0.9% sodium chloride is an isotonic crystalloid commonly used in shock, dehydration, and hyponatremia. It expands the intravascular volume and is widely used for initial fluid resuscitation. Ringer lactate is a balanced crystalloid solution containing electrolytes and lactate. It is preferred in trauma, burns. Dextrose solutions such as 5% or 25% or 50% dextrose provide glucose and free water. They are used in hypoglycemia and maintenance therapy, but they are not suitable for resuscitation in shock because they don't adequately expand the intravascular space. Fluid therapy must always be individualized, taking into account the patient's clinical condition, volume status, electrolyte balance, and ongoing losses. When prescribed correctly, intravenous fluids play a vital role in stabilizing patients and supporting recovery in both emergency and routine clinical care. Neuropathic pain therapy. Neuropathic pain is commonly managed with the combination of pregabalin and methylcobalamin, which together target both symptom control and nerve repair. Pregabalin acts by modulating voltage-gated calcium channels in the central nervous system. This reduces the release of excitatory neurotransmitters and helps decrease neuronal hyperexcitability, thereby relieving neuropathic pain. Methylcobalamin, an active form of vitamin B12, supports nerve regeneration, myelin synthesis, and axonal repair, helping to improve nerve function over time. This combination is widely used in conditions such as diabetic neuropathy, radiculopathy, post-herpetic neuralgia, and other peripheral nerve disorders, where it helps reduce pain, improve nerve function, and enhance overall quality of life. When prescribed appropriately, and monitored for tolerance, this therapy provides an effective and well-established approach to managing chronic neuropathic pain. We have now completed our journey through the essential instruments of general medicine. These instruments are not just tools, they are extensions of your clinical knowledge, your judgment, and your responsibility towards your patients. Every time you pick up one of these instruments, you are making a clinical decision that can influence a patient's outcome. Use them with knowledge, use them with skill, and above all, use them with compassion. If you found this session helpful, do support Clinical Horizon by liking, sharing, and subscribing for more high yield medical content. Thank you for watching. Stay safe, stay skilled, and keep saving lives.